looking at our forecasting and mapping that demand with an average of uplift. We've put additional vehicles on. So I think we're doing really well, and it's busy, but we're coping.
Wonderful, thank you, Will. And also now Teresa Cope, Manx Care CEO, no stranger to this programme. Now, we've heard a lot about Nobles Hospital being at Opal 4 status over the past few weeks. Tell us exactly what that means.
So Opal 4 means we are at our highest level of escalation and under significant pressure. So the Opal framework goes from Opal 1, which is effectively business as usual, right through to Opal 4. And Opal 4 is judged by essentially what does our staffing look like across the organisation, how many beds do we have available, are our ambulances able to offload in a timely way into the emergency department, how busy the emergency department is, and whether we have patients in hospital who are ready to leave hospital, but they are delayed in that discharge for whatever reason. So we describe that because ultimately we need to take additional actions when we're at Opal 4. So in order to de-escalate that position, we have action cards, which means across the entire organisation, we take additional actions to ensure our patients are being treated safely, but that we decompress the hospital. And that means actions taken across all the teams within the hospital, but also we also ask of additional actions outside the hospital. And we also want to get that message across to the public, wanting them to think about where else they could get care. So it's that choosing wisely approach, which is when we're in pressure, we really want the public to think about using things like the MIU service up at Ramsey District Cottage Hospital, using our community pharmacies, self-care, making sure, just the basics, like you've got enough medicines, paracetamol at home in order to self-care wherever possible.
We're going to go to the lines in just a moment, but I just want to talk a little bit more about Opal 4 because many people get very worried when they hear that headline. You mentioned a lot of things that push us into that status, staffing and bed spaces, etc. What has it been that's really pushed us into that over the past few weeks?
I think it's an accumulation. It's an incredibly busy time going into winter. We always anticipate it to be more busy than usual. But what we've seen this year is a real increase in acuity of admissions. So when we look at the stats compared to last year, whilst we on the whole haven't seen any more numbers of patients through the emergency department, certainly those patients coming through have been sicker. And over the Christmas and New Year period, we saw an increase of admissions due to flu A. So at our peak, we had 18 patients in hospital who had flu. And we've also seen a real increase through the GP out of hours. So the Manx Emergency Doctor Service saw 86% more calls on Boxing Day this year than last year, and 44% more calls on Christmas Day. So it's really signalling that the system has been under a great deal of pressure. Now, I think it's really important to describe that when we talk about Opal 4, yes, it does mean we are incredibly busy and under pressure, but we take the Opal 4 actions to decompress. So we stop doing some things which aren't clinically as urgent. We make some changes. We stop non-essential meetings because our focus during those Opal 4 times when we're under pressure is to make sure all of our focus and energy is around treating the patients and ultimately allowing the hospital to flow correctly, that we've got the right staffing levels and we are taking the right actions.
Dr. Gareth Davies, I'm guessing that the ideal is Opal level 1?
Oh yeah, that would be really good. That would be really good. But yes, that is business as usual. But even business as usual, I think across healthcare systems throughout the UK and beyond, even at that level, are incredibly busy. We're seeing an execrable increase in the number of patients that are accessing healthcare, whether it is primary care, urgent care or emergency care. So even down at Opal 1, the place is busy.
And I know there's been a lot done with signposting over the past few weeks, encouraging people to choose well. Mm-hmm. How many people would you say are turning up to our emergency departments who don't actually need to be there?
I think inevitably there are people that come to the emergency department that can be seen elsewhere. There is, a rich array of services out there in the community for people who've got either urgent or emergency healthcare needs. Therese has alluded to several of them, whether it's the minor injuries unit, it's pharmacists, the dental service, the eye services down at Specsavers. There are many ways people can get both urgent and emergency care that isn't just available in the emergency department. So we'd really encourage people to look at what's available out there in the community for them.
Okay, can I ask you all to put your headphones on, because we have got a caller now. We can go and join Julian on line 1. Good afternoon, Julian.
Oh, hi, Beth, and hello to your guests.
Hi,
Hello.
Hi, there.
Hi. My question today is inspired by the lady who left a voicemail on last Friday's Mannin Line asking me about the opt-in or opt-out status for organ donation on the Isle of Man, which Beth answered correctly as opt-out here since February 2021. And her voicemail leads me to ask this question. If in the future, if assisted dying legislation is passed, if an assisted dying person on the island wishes to donate their organs, at what point after the euthanasia procedure would they be declared dead, and when would organ harvesting commence? In other words, what is your definition of dead?
Would anyone like to answer that question?
I think I'll try and take that. But I think, the assisted dying legislation and the discussion is in its very, very early stages. And Julian, I know you and I have talked about this on previous calls. We are nowhere near, I think, describing how we would sort of implement and work round that if it ever was to be brought in on the island. So I guess in short, I don't want to evade answering your questions, but I think it's far too early to really understand what would be the operational implementation of any legislation put in place around assisted dying.
Thank you very much. Thank you so much, Julian, for getting in touch with that call. Just want to talk a little bit more about the Opal 4 status, the pressure on our health services. And it's something that we're told about a lot, is the problem people have getting GP appointments. And I wonder how much of that presentation at our emergency departments could be avoided if people felt that they could speak to somebody and allay some of their fears.
I think Gareth might be able to answer this, but I think, it is inevitable that all of the system is under pressure, and we have absolutely acknowledged just how busy GPs are. We've done some comparison, and some of this is what we discussed at the board last week. Some of our response times, both in terms of primary care, ambulance times, and the performance we're able to achieve in our emergency department, whilst it's not exactly what we would want, it's very evident that the Isle of Man health and care system is faring much better than the UK health and care system at this moment in time. We do need to be able to have a more comprehensive primary care offer, and that's where primary care at scale has evolved from, recognising we need to build more consistent teams around our primary care provision, have an increased offer, have additional professionals working in the out of hospital space, which ultimately mean we've got a very comprehensive out of hospital and primary care offer using pharmacists, opticians, extended scope physiotherapists, additional practice nurses, advanced nurse practitioners, paramedics in primary care. There's a workforce there which really will strengthen primary care, and good quality primary care is the absolute bedrock of any effective health and care system. But we want to keep people local in their communities as far as possible.
But Dr. Gareth Davies, I suppose what I'm getting at is that when people feel unwell, when they have concerns, they need to speak to somebody straight away to make them feel better, even from that point of view.
Yeah, absolutely. And there are many ways by which that happens, and certainly one of the services that I look after, which is the med service and out of hours general practice service for evenings and weekends, there is that ability to phone up and speak to a healthcare professional.
Although I did see, actually, sorry to interrupt you, but
Yeah.
I did see over Christmas people saying that they were struggling to get through to meds.
Yeah, and I think that that is fair, that over the Christmas period we did get swamped, and there was a degree of wait for people who were calling the service, and that's something we are trying to address. But I just really wanted to go back to another point that Teresa made earlier on, which actually for our community, the complexity of the patients that are now coming to the emergency department is a paradigm different to a couple of years ago. So the patients, we see a very elderly demographic in the emergency department on the island, and the patients that we get are very rarely simple. They very rarely come in with one emergency healthcare problem. They will have many comorbidities that are affecting them, and it just takes one particular disease or problem to set all of those off. So patients are more complex now, and we find ourselves having to admit more patients than we historically did, and I pass the patients on to a SHARCU. But I think we're, even in that domain, we are still in a far better place than the UK. Although things do feel tight and under pressure on the island compared to what is going on in the UK, we are still providing quite a good service compared to what you see on the news across, and that's whether it's waiting in emergency departments or the number of patients that are admitted. We still are outperforming our UK partners.
Dr. Pam?
Yes, just to key into what Gareth said about the complexity of the patients we are seeing. Our statistics have shown time and again from 2018 up to this point that 60 to 70% of our admitted patients are patients who we would describe as having frailty. So these are individuals who are over the age of 75 with usually 2 or more frailty syndromes, so from falls to cognitive impairment, dementia, polypharmacy, which means they're on lots of different drugs, carer strain, so families can't cope, there's not enough provision in the community for social care. So that demographic is what we're seeing in hospital, and therefore these are individuals who need to spend prolonged periods of time, which then means that there is an exit block, and therefore although the numbers haven't increased significantly attending ED, it means though that the throughput of patients is delayed, and therefore ED reflects that pressure.
So what plans are there then to address that? If that's, I suppose the term would be bed blockers that people understand. What can we do about that?
So, and that is a systemic problem, challenge rather. It's a demographic challenge which is now prevalent around the world. The population pyramid is inverse. You're getting older people in terms of numerical proportion being as many or even more than those who are younger. So that is something that is beyond sort of Nobles, perhaps beyond Manx Care. It is one that is a population-wide issue, and I will hand over to Teresa. She knows, it's what actually is propelling the need for transformation.
That's right, and that sort of aging profile is what we're really cognizant of. So Manx Care has invested in a frailty programme, so community geriatricians, frailty lead nurses, a dedicated ward for frailty, because this is about taking a very proactive and preventative approach to identifying frailty in the community, undertaking comprehensive geriatric assessments, and really putting a lot of local support in. So we actually try and keep people well and independent in their own home through proactive interventions, which sort of try and counteract frailty. At the other end, then when people come into hospital, we really should be aiming for them to spend the shortest amount of time in hospital before they become medically well. And we should be looking at supporting their rehabilitation and reablement needs in the community. So again, the second part of that is around investment in what we would call the intermediate tier, that suite of provision which sits between hospital-based services and primary care. And those are the two strands of investment which Manx Care, through DHSC funding and through our mandate, we are putting in place, because that is about supporting people to stay at home, and putting in steps to make sure that people can stay well and step up and stepped down from hospital-based care.
Well, let's go back to the lines now. We can join Mary on line 1, who has a comment or question about the signposting leaflet for Manx Care. Good afternoon, Mary.
Hello. Yes, I've been reading through this leaflet, and I was just wondering, vulnerable people, and there are quite a few vulnerable people around still, who are trying to isolate as best they can, and if they actually get COVID, the original instructions were to ring the GP straight away and identify that they were eligible for antiviral drugs. Well, and I've been all through this little leaflet, and there's absolutely nothing in here about vulnerable people. There's just a small piece about COVID-19 symptoms and going online and not going into health and social care settings. But there's nothing about vulnerable people. A lot of the vulnerable people are elderly, and a lot of them are not online anyway. So what are the actual instructions if any of those people do go down with COVID
Dr.
at
Pam.
the moment?
Yes, I'm sorry to hear that the message hasn't gone out effectively to the public around what pathways are available to patients who are vulnerable. And just for clarity, those we would consider vulnerable are defined, around those who have cancer, for example, or who are on treatments that render their immune systems vulnerable to infections. And so there is a definition around it. So it may not necessarily chime with what people would consider vulnerable, but the message really is that people who fall within those groups ought to call their GPs. There is a period of time, a window of opportunity of 5 days within which they can then receive antivirals, and we have a pathway through the ambulatory emergency clinic, which is based in the emergency department, and so it is that call to GPs which should then activate a call to the ambulatory emergency clinic, and then there is a discussion between the GP and the AEC because these are drugs that have exclusion criteria as well as inclusion. So particularly the first line one, which is Paxlovid, it interacts with quite a lot of medications that patients take, and so that discussion with the GP is absolutely important to then decide which of the treatments are available to the individual. So for some reason, and I'm sure we'll take this back, that message perhaps has not been delivered appropriately, but it's a system that's up and running that in fact is oversubscribed. We've been very pleased with the uptake, and I think the majority of people who've needed antivirals have received them. Thank you.
Does that answer your question, Mary?
Yes, it does. Yes, it's good to know that there is a time limit to get the antiviral drugs because, as you know, it's very hard to get through to the GP. I mean, you could test positive in the morning and still be trying to get through to the GP in the afternoon. But it's good to know that it isn't such an urgent delivery of the antiviral drug. There is a gap that, the time before you can still have them, shall we say.
Wonderful.
Yes.
Thank you so much, Mary. Appreciate you calling your question.
Thank you.
Thank
Bye-bye.
you. We can go to line 2 now and join David. Good afternoon, David.
Hi, Beth, and the panel. Just want to give you a bouquet, not to you personally, Beth.
Shane?
It's the hospital itself and the Scottish team that are over and doing these initiatives. I was one of the pack that got done with a knee, and I'm into my 10th week now, and I'm able to walk without a stick. Can't carry much tea without spilling it, but I'm still there. So I want to give that positive out. That was a great initiative that was done as far as the Isle of Man was concerned, and I'll tell you for why. The people were treated on the island. I was only in 2 days, and after 2 days in the private ward, not that it wasn't great, I was out. They said, right, we want the next people in. They were doing 3 a day, I was told. That was either 3 hips or three knees, and that must have put a good dent in the outstanding things that were to give a quality of life to some people, never mind myself.
Brilliant. Thank you so much, David. Teresa?
Yeah, no, thank you for that feedback, David. And I'm really pleased you're on the mend and you've had a really good experience. We knew that we inherited really great waiting lists, far too big and impacted by COVID. We were really fortunate to get an initial tranche of money from the DHSC and from government. And obviously the additional £18.3 million announced at the end of last year is really welcome. The team from Scotland are working in conjunction with our own orthopaedic surgeons. And as you say, we're able to get a level of efficiency through our theatres, and the average length of stay for a patient who's having a joint replacement is 1.4 days. So when we think about the availability of our beds and our capacity, we are making really efficient use, which means we are able to absolutely treat the maximum number of patients, and with that sort of physio wraparound support. So it has been incredibly successful. We continue to commit to the trajectories and report back on that regularly, and we talk about it on this show quite a bit, because it is really important that we respond to the waiting list challenges.
Thank you very much, and thank you, David, for that. Just a quick text before we take a short break. DM says, I had to call meds at the weekend. It couldn't have been easier. I got a quick call back from a doctor. He was very helpful and agreed I needed medication for my asthma. He offered to see me, but I felt it wasn't needed. A prescription was sent to my local chemist, so within an hour I had the tablets. A very quick and efficient system. Any other thoughts? 166 177 studio@manxradio.com, or you can call 66 13 68.
This July, Avon's calling as Tours Isle of Man journey to Bristol. Join us for a week from the 12th of July as we travel to the historical city in the south of England, taking in the gorgeous Cotswolds and scenic Somerset countryside on our way. Staying in beautiful hotels and making friends along the way, take in the stunning Avon Valley's hills, cathedrals, harbours and shopping opportunities. And then we'll bring you home straight to your door. Find out more on our website.
Visit tours.co.im. Island Hearing Limited, your local hearing care specialist since 2009, with branches in Port Erin and Ramsey. We provide the very latest hearing aid technology available, which you can try at home, with excellent aftercare and a wax removal service available using microsuction. Give us a ring on 830 722 or visit Island Hearing at One Station Road, Port Erin. We're happy to help. Island Hearing, always listening.
At Isle of Man Energy, our ultra-efficient boilers are priced from just £34 a month, with extended payment terms over 5 years and 9 years warranty. It's just one of the many things we're doing to help save you money and reduce energy. If your boiler is due an upgrade, or you'd like to find out more, call the Isle of Man Energy team on 644 444 or visit isleofmanenergy.im. Isle of Man Energy. Energy for every generation. Subject to status, T's and C's apply.
Office World at Spring Valley Industrial Estate is home to the island's largest stockist of both office and home office furniture. With ergonomic sit-stand workstations and posture seating solutions, extensive ranges of both general and home office desking and seating, and a huge range of complementary desktop accessories. Many popular items held in stock on island for speedy delivery or collection. Office World Spring Valley. Open 9 till 5:30 Monday to Friday.
Office World. Manx Radio.
The Mannin Line, brought to you by NetZeroMatrix.com.
the Isle of Man's main net zero progress website.
It's just after 12:33. With regard to Mary's call a short time ago, I just want to let you know that we've had some clarification, and the antiviral information was not included in the signposting leaflet because it's only relevant to a small portion of the population. I want to go to the head of the ambulance service, Will Bellamy, now. Now, Will, we've heard some pretty stark news from the UK in recent days about ambulance waiting times. How many ambulances do we have here available in the Isle of Man during the day, first of all?
Yeah, so during the day we have 4 frontline ambulances and 1 urgent transport service. So takes our GP urgent transfers to the airport, discharges, stretcher discharges, and then 3 vehicles overnight.
Now, I saw some information that said, I think it's roughly 13,000 calls a year to the ambulance service. In 2005, there were 5,000 calls a year, roughly. Yet the model of ambulance provision hasn't changed. People wonder why that is. Yeah,
absolutely. I think from our humble beginnings, the ambulance service here on the Isle of Man has been seen as, at the end of the patient journey, a transport service of taking people to or from hospital. And I think as we've continued that growth in activity, we have to really now look at our operational and clinical model for paramedics to make sure that we provide the best care for patients and for the island.
How often would you say ambulances are called to people who don't really need them?
So I don't think I would say people don't need them. You know, healthcare, accessing healthcare is so complex, and people, you know, work with a brand that they know and trust, which is 999, and we have a model that's 100% response with 2 people in an intensive care ambulance, and actually those patients that could we deal with them better, signpost them over the phone, or even access other services and book them into it, is surely much more effective and efficient way.
Well, that takes us on to the news that we've been hearing this morning about clinical navigators in the Emergency Services Joint Control Room. Explain that to us in layman's terms.
Yeah, so basically it's putting a clinician into the control room to work with our control room staff, just to oversee some of the 999's calls, support them if they've got any clinical questions, but they are experts in their own right, and we're not wanting to interfere in that process. But also when patients are identified of low acuity, so the ambulances categories are categorised from level 1 to level 4, or Cat 1 to Cat 4, and 1 being the most extreme, so you're not breathing or you're fitting, and category 5 is we say that we can potentially deal with you over the phone or send specialist clinicians. And we did 2,500 of those calls last year alone, and we responded to them all with ambulances. So we're just going to look at those calls, screen them, see what we can do and see what's more appropriate, and have some conversations with people. But as I say, having conversations with them and see how we can appropriately deal with them.
When's this going to start then? So
we've never done this before. You know, we're in uncharted waters from a clinical point of view. So we're just taking our time. We're looking at how we can do the clinical governance, train people, test all the systems, test how we've designed it to see whether it works before we put patients for obviously patient safety. So we're looking to kick off substantively from the new financial year, from April onwards, with people but between now and then we are testing it. We will have clinicians that have gone through training, been supported from colleagues from across who do this as their day job, their bread and butter, and then ensuring that it's safe for what we're doing.
Well, as you say, there will be clinicians, but that's a tremendous amount of responsibility on the person assessing the call. How confident are you that the caller will have faith when they're told an ambulance isn't needed?
Absolutely. So it's not just a clinician making their own decisions off the top of their head. They're working with a triage system to rule out, just to guide the clinician to make sure clinical red flags have been excluded for whatever the reasons are, and have that discussions with the patient to manage expectations, to understand what their concerns are, and it's not a done to, it's done in collaboration with them.
Okay, let's go back to the lines now, and we can join Andrew on line 1. Good afternoon.
Yes, hi there. Good day to you and your guests. Just following up, please, from your previous caller who was talking about meds and how quick and efficient it is. I was wondering from the meds team there that have they got any sort of statistics to reflect how many calls they're perhaps getting because people are having difficulty getting through to their own GPs? Because, if you're phoning the GP, and you give 3 times, say, over a morning, and you can't get through, you think to yourself, well, why should I carry on? Let's just phone meds.
Yeah.
Okay. Dr.
Thank you, Beth. Thank you, Andrew. And it is a really important observation, and I think we're all very much aware of the lack of capacity at the moment in primary care in some areas, and there is no doubt that some people are struggling to get hold of their GPs in hours' time, and they are defaulting to the med service, and we recognise that, and we are monitoring those numbers, but we should emphasise that actually that lack of capacity is recognised in primary care, and I think Teresa could probably do a much better job than me than explaining the efforts that are going into improving that capacity so people aren't defaulting to med. So yes, Andrew, you are right. It is happening, but there are things that are being done about it, and I'll hand over to Teresa.
I suppose, Teresa, it just goes down to what we were saying before about people sometimes just need to speak to someone, as is going to possibly happen with the clinical navigators in the Emergency Joint Services Control Room. And it seems that we've made advances in some ways, video conferencing and whatever, but it feels like there aren't enough people to answer the calls, and surely that would take pressure off elsewhere if that was to happen.
Yes, it would, and it all links back to being able to have different ways of delivering healthcare. So, the clinicians in the emergency joint control room is one way of ensuring that the patients who absolutely do need the ambulance get the ambulance, and other patients who can be given advice and guidance over the phone, potentially could be directed into a different type of service is what we're trying to achieve. And I guess that's layered all throughout Manx Care. We really want to reduce the level of demand on the urgent and emergency services by having a much more planned, preventative model of delivery across all our services.
John's been in touch to ask, has any thought been put into opening walk-in doctors' clinics like there are in the UK, 24 hours a day, say one in Douglas, Ramsey, Peel, Castletown, no appointment needed? Maybe that would take the pressure off the doctors and ED department.
Yes, it's certainly one of the options, and myself and Dr. Oliver Ellis, who's the medical director of the Primary Care Network, are in discussions about some of those other options that exist to try and help the resilience of primary care. Primary care at scale, which is sort of our new target operating model for primary care going forward from April. Does sort of describe some of that, but it's really clear that primary care is under massive pressure, and we need to look at other solutions, including potentially virtual solutions, to aid us in that, to give us some resilience.
A message in from texter ending 692, and I think this is an interesting point. Your panel keeps going on about us old people that have lots of things wrong with us. They should consider that for 48 years we paid into the NHS for now. Dr. Pam, I'll come to you on this one, because there is that feeling that when we constantly talk about our ageing population, people who are of that age are made to feel like a burden.
Well, I'd just like to say I'm a geriatrician, so my job is to look after older people, and we cannot be further away from that idea that we discriminate against our older people or make them feel less welcome. They are entirely appropriate in terms of the care that they need and deserve, and so, as Teresa had mentioned earlier, it is with this in mind that Manx Care has employed even more geriatricians. We recognise the fact that the majority of patients we have in the hospital are of that group, and we don't feel that they shouldn't be there. We feel they deserve a much better service than they're getting, and it's it's in terms of delivering that service in a way that is that they would want, that we endeavour. So we do not in any way at all encourage that thinking that they don't deserve to be treated. The caller is absolutely right. They've paid into the system, and they should get every ounce of compassion and treatment that they deserve. Thank you.
12:43 on the Mannin Line. We'll be back after this.
Manx Utilities are currently replacing prepayment customers' key meters with new smart electricity meters in homes in Douglas. As a smarter pay-as-you-go customer, you can access our new Smarter Living app to keep an eye on your energy use in real time and to top up your credit quickly at a time that suits you. You can also top up at selected stores and via our website. To find out more about the changes, visit the Smarter Living page at manxutilities.im.
This old house needed new windows. This old house needed a new door. And with DPM Conservatories, we got all that and more. Now our bills are lower and the house is warmer too. We're cleaner and we're greener since we swapped our old for new. Stunning A+ rated replacement windows and doors, expertly fitted by DPM Conservatories. Phone 612 333 or find them on Facebook and swap your old for new.
During the colder months, it is important to keep yourself and your home well and warm, especially if you are older or vulnerable. Advice and support ranging from the best ways to keep warm to tips on reducing your home energy costs is available. Visit costoflivingsupport.gov.im or call us on 68 62 62.
When the Mannin Line's not on air, call Manx Radio to leave your opinion for broadcast on 682 631. The Mannin Line, brought to you by netzeromatrix.com, the world's leading carbon register and validation ecosystem.
Just coming up to 1:45, we're joined by several guests from Manx Care. We're going to go straight back to the lines and join Diane now, first on line 1. Good afternoon. Hello?
Hello.
Oh, hello.
Hello.
Hi. Sorry, I don't know whether I got the wrong name there. Who's that?
It's Nigel.
Oh, Nigel. Doesn't sound like Diane, but anyway, what's your question, Nigel?
Well, I'll tell you what it was. Just going back to your antiviral COVID tablets. I was diagnosed in July with COVID, and I have a really aggressive prostate cancer. Went to see my GP. He admitted me to A&E straight away, which I went into. I was in agony, joints, headaches, everything that COVID goes with. They weren't sure what to do with me. I was in for about 8 hours. That was fine. They were going to admit me to a ward, and then they decided they were going to try me on this antiviral tablet. So came home, took the tablets. Within the first 4 hours of going back to bed and then waking up, the pain and everything, and this is no word of a lie, had near enough disappeared. I Googled it and read the reports about it, about some people say they can have an instant response with it. The lingering taste that you can have over the weeks period of tablets was there. I had all of that, but I couldn't believe the instant response of these tablets actually brought me back round again, and I took the week's tablets. Now, I found out the cost of the tablets, which was about £600. So they'd sent me home, put me on the tablets, and I was fine. What I don't understand is why do they not, and I don't mean dish them out willy-nilly, but give them to more patients that are possibly going to go in hospital with COVID on the grounds that the tablets do work, and they'd be a damn sight cheaper than sending people home and keeping them in hospital.
Okay. Dr. Pam?
Right. I'm really pleased to hear that you had an excellent response to the treatment, which is exactly what we envisaged in setting up the pathways. In answer to your question, I think we have to reflect on the fact that COVID is a relatively new disease. Many will remember the controversies around various treatments. And so a number of these treatments are novel, and you don't sort of roll them out widespread. They are actually also really very strong medications that many of them have been used in cancers and so on. So they are ones that are not without risk, and not without a lot of interactions with existing medications, as I've previously mentioned. So they have to be given to a narrow base of the population, and only when they're proven to be safe in those populations as well as beyond. And safe, I mean by well-structured studies that they will not then be given out on a wider scale until they understandably attain those precise parameters for safety and effectiveness.
Thank you very much indeed, and thank you to Nigel. Let's go back to the lines now, and I think we can join Howard on line 3. Is that you there, Howard?
It is. Hi, Beth. Good afternoon to your panel. Just a question that it'll go particularly to, I think, is Miss Cope, is it? Is
yes.
that who you got with you? Yeah. One thing you read in the paper about GPs and various other medical practitioners within the UK, when they're earning their wage, like everybody that's in a job, they're paying into a pension scheme. And the UK government put a ceiling on that, which meant that once they reach that, it's going to be cost prohibitive to remain working. And they are retiring what we would term as early and moving on to pastures new. But this has led to a depletion of GPs throughout the whole of the UK. Is a similar situation applicable to the Isle of Man? Does the pension scheme have the same restrictions in the ceiling on the pension pot?
Teresa.
I'm not a pensions expert, but it isn't the same as the UK. There aren't the same restrictions on the pension pot as what there are. So, we're not seeing that as a reason why clinicians are essentially leaving the service. But I think it is something that we need to continue to look at to ensure that sort of the pension contributions and the wider pension framework do support our clinicians to continue working for as long as they want to continue working. And I've certainly got some meetings set up with the Pensions Authority here to progress some of those discussions.
It's interesting, you were saying at the beginning of the programme when we were talking about the Opal 4 status, that part of the factors that feed into that is staffing issues, so recruitment. Would you have a ballpark figure for how many clinicians' positions that you're currently seeking to fill?
We've got about a 20% vacancy factor rate across the entire organisation, and we employ around 2,800 people. So it's a significant vacancy factor. And if you listened to our board last week in public, we're starting to take some steps. We've already tried to do a number of things in order to respond to that vacancy gap. But I think where we're at as Manx Care is recognising that something a little bit more fundamental, bold, has to be done. And so we have talked extensively about increasing the number of domestic training places for all professionals, but particularly for registered nurses, and also what we can do around the bursary to increase that.
Accommodation issues faced by an ecology nurse were highlighted on Manx Radio last week. He said if he couldn't find anywhere to rent which would accept his dog, he'd be forced to return to the UK. It does feel sometimes like not enough is being done to make the island an attractive proposition. I mean, we used to have the nurses' home. I suppose it's quite nice for people who do stressful jobs to be together, to be able to talk things through. What is there to attract people here, really?
Yeah, so Manx Care is part of a wider government piece around trying to identify, affordable accommodation, flexible accommodation, not only for sort of individuals, but also to support families. We want to attract families, and that means bringing across people who have children, who have pets, and being able to source appropriate accommodation for them. Manx Care has recently agreed a development which will enable us to increase our housing stock for registered workers. But it is a wider government response, but we are linked into those discussions, and it's really important that we remain attractive and competitive when we think about the levels of vacancy that exist across healthcare. We've got to do things which really enable people to be able to come here. We know it's quite expensive to live here compared to some parts of the UK. So anything we can do in that space to be attractive is really important. And that wider piece of work with the Department for Enterprise, Department for Health and Social Care is important.
I had a nice message from Tommy, who's been on to say the ambulance service saved his life many years ago after his heart had stopped. Says he wouldn't be here if it wasn't for them. But a text in, Will Bellamy, asking, can you explain why on a Saturday daytime it takes 1.5 hours for an ambulance to respond to a stroke victim in Douglas?
Yeah, absolutely. So, first of all, I'm sorry to hear that experience was had by a patient, and although I can't talk about specific cases, if they wish to get in contact via MCALS, I'll certainly take up a review of what had happened. I think from what perspective, if people have strokes, chest pains, it gets prioritised as a category 2 on the whole, which is an 18-minute response time on average we need to have. Last year we achieved 13 minutes response time. So it's not this is an exception. It's not the standard that we try or that we expect to achieve and want to achieve. And apologies that did happen. But again, if they wish to contact offline through MCALS, I'll certainly look into the case.
Just a few minutes left of this programme. I want to come to you, Dr. Pam. Obviously, the best thing would be people not being unwell in the first place. How many of the ailments that are presented at our EDs around the island would be preventable if maybe people took a little bit more responsibility for their own health?
Thank you. And I think that's a question that I might share with Gareth. But there are quite a number of chronic diseases that feed into ultimate illness, often years after the behaviours that predispose to these conditions. So there's a wide range of them. From diabetes, hypertension, obesity in particular. Those sort of 3 big ones. They then lead to systemic problems that then ultimately manifest in disease. We also cannot but mention behaviours around smoking and alcohol consumption. They also play a part. So it's a complex interplay of bodily dysfunction as well as behavioural issues that then ultimately lead to disease. So it's all the sensible things people need to think about. Nobody is coated in Teflon, and these behaviors start in much younger age groups, and we're seeing that the disease that people manifest with are occurring much older, particularly alcohol-related complications.
Dr. Gareth Davies?
Yeah, I'd completely agree with Sharku that there are many presentations to the emergency department where actually diet and lifestyle are at the heart of their issues. And, if there's one thing that I think we would all like to say is that as a community, everyone taking greater ownership of their healthcare is a fundamental step for us all to get this right.
So a lot covered over the past hour. I'm aware I've got some texts and emails that we haven't been able to get to. So I think what we will do, if everyone is able to stay for a little bit, we'll go through those texts and then I'll put that up as a podcast a little bit later. But thank you very much to our guests on this programme, Dr. Ashaku Pam, Dr. Gareth Davies, Will Bellamy, Head of the Ambulance Service, and Teresa Cope, who is the Manx Care CEO. If there's anything you've heard today that you'd like to discuss on future programmes, or you'd like to leave us a message that we play out in the programme, 682 631 is the number to call, and you'll be able to listen back to this programme as a podcast very shortly. It will also be available as a video to watch, which we're all delighted about in here, I can tell you. That is all for today, though. Thank you so much to the programme's producers, Chris Quirk and Howard Kane. I will be back, as I say, tomorrow at midday. It is an open line then, so if there's anything at all you want to talk about, you can get in touch, 66 13 68. As I say, leave a message if you'd rather do that. Coming up next, it's Chris Quirk with 1 to 3. Have a great afternoon, and I'll talk to you tomorrow.